Yeah, thank you so much, Alan. And I try to follow up on the excellent presentation you've just seen and provide you a little bit more background information. Next slide, please. So you've already seen this table here from the Ontario Science Table. That's how we are supposed to use the drugs or make a decision on the indication here in Ontario. And as Alan already mentioned, it's based on the risk of hospital admission. And that risk, as you can see on the next slide here, is based on this table, which is based data from BC. And what I try to do here, you see all the red boxes, and whatever within that red box would be 5% and more risk of hospital admissions among males. As you know, females have a slightly lower risk in terms of severe outcomes from COVID infection. But for males, you see that it's more or less reflected in that table. It's a little bit more simplified, I would say, in the table, so a little bit less granular, but easier to apply than if you were to work with the table you see here. And as you probably all know by now, when you're looking at a less than 20-year-old with 0 risk factors and then vaccinated, your risk for hospital admissions approaches 0, while in a 80+ patient, 3 and more risk factors, even if triple vaccinated, so even if boosted, you still have a risk of more than 10% for hospital admissions, and that's what's being reflected in the indications for treatment. Next slide. Now, these are the drugs I will touch on in a little bit more detail. You've already heard about Paxlovid. I will talk about Sotrovimab as a monoclonal antibody, Remdesivir, the Pine Tree study, and very briefly Fluvoxamine as well. Budesonide you've already heard about, which can be used in the higher risk category if the other drugs cannot be used, or for the standard risk if you feel, yeah, I would like to offer something for the patient knowing that they don't qualify for the more expensive, but also more effective treatment options. Next slide. One issue that I would like to mention up front, because that's true across the board in the data that I'm going to show you, is that the data we have is first and foremost in non-immune, non-vaccinated patients, and typically high-risk patients that haven't been vaccinated and haven't had a previous infection. And we sort of generalized that data to the vaccinated population or patients with previous infections without exactly knowing how big that remaining effect remains. But again, assuming that you have more than a 5% risk of hospital admissions, you may still have a large enough absolute risk reduction to justify those treatments. First, here, Sotrovimab, the one monoclonal antibody available in Canada that's still active against Omicron. This is the original study here that shows you an adjusted relative risk of 0.21, so roughly an 80% risk reduction in hospital admissions in patients who had been treated with Sotrovimab. Again, patient population here are patients with multiple risk factors and unvaccinated. Next slide. BA2 is taking up speed, as everyone knows at this point. By end of February, we were in Ontario at roughly 17%. Some data suggests we are probably at around 50% at this point of BA2. So it becomes important how well does Sotrovimab or the other monoclonal antibodies hold up against BA2. And unfortunately, it looks like, in particular, Sotrovimab gets another hit compared to its activity against BA1 or BA11, which had been the sub-lineages we had been dealing with so far in the Omicron wave. So here you see a factor increase of almost 50 for Sotrovimab compared to the original strain. However, it looks like Regeneron may become potentially an option again. The issue here is This is in vitro data, and we don't know exactly how this translates into in vivo data. So we continue to monitor and watch and see whether there's more data out there that gives us an idea of how effective these treatments truly are in the setting of sooner or later predominantly BA2 COVID infections. Next slide. Another IV options that you have that successfully reduces the risk of hospital admissions is remdesivir. This is the Pine Tree RCT, published late 2021, and it shows a reduction in similar ballpark as you can see as for sotrovimab. So here the hazard ratio of 0.13. So a reduction again in the range of roughly 85% here. They used hazard ratios, however, but just to give you an idea, probably same ballpark in terms of efficacy and hopefully eventually effectiveness in the population that we are treating. You can also see on the right-hand side, when you look at the Kaplan-Meier curve, that the vast majority of events, which here was hospital admissions or death from any cause, occurred within the first week after treatment. Treatment here was given within 7 days, which is probably what we've all seen. Typically after a week, if people go into that more inflammatory stage, as Alan already explained to you, and that's when we see hospital admissions being required. Of note here, they had 0 deaths in both groups, so the effect here is really driven by preventing hospital admissions, in which remdesivir was highly successful. Next slide. So in summary, sotrovimab and remdesivir for mild disease in the community, both are IV infusions which require an outpatient clinic setup, a formal referral process to make sure that you get the right patients into your COVID clinic. The data supports benefit in the non-immune population, as you've seen, a very significant benefit. And as I mentioned, we are generalizing that to other high-risk population or partially immune individuals at this point, assuming that we still see a significant absolute risk reduction. Time window is up to 7 days from onset of symptoms. Supply concerns, currently not the case, so you can forget this. In the past, we had periods where we were short on sotrovimab, then we were short on remdesivir. Currently, we are relatively well stocked, at least in the province of Ontario. Next slide. As I mentioned, a couple slides on fluvoxamine or Luvox. This is off-label use, obviously. Fluvoxamine is a selective serotonin reuptake inhibitor, a drug that IV physicians would never have dealt with in the past. And the effect here is thought to be the immunomodulatory effect that this drug has that can, again, prevent that more inflammatory, more severe stage later in the infection. This was a very early, small study here, 72 and 80% patients in each group, respectively, published back in 2020, where it did show a significant reduction in clinical deterioration, which was the outcome in this study. Next slide. This was taken up, of course, and the larger RCT was conducted by a group that included people from McMaster University. Again, small minority vaccinated, so they had a few, but only a very small group that was vaccinated. So the data is first and foremost based on non-immune patients. They were treated with 100 milligrams BID for 10 days, again, started within 7 days of symptom onset. And as you can see in the table here, a risk reduction in the range of 30+% for the outcome here, which is again risk of hospital admission or longer stay in an emergency setting. So not as effective as the drugs that I previously showed you, but still a sizable effect, as you can see. Next slide. Caveats here is interactions that include the risk for serotonin syndrome with MAO inhibitors. The Ontario Science Table recommends to consider phasing to reduce the side effects, starting off with 50 grams once daily, and then to increase the dose to 50 to 100 milligrams BID based on how much side effects people might have had after the first dose. Duration in the trial was 10 days. The Science Table recommends to consider up to 15 days here. Next slide. Another oral option not yet approved and available in Canada is Peerreview, Lagevrio. Only this one slide here because it's not as relevant. You may have heard about the trial very early. The interim analysis showed a quite significant relative risk reduction of 50% again for the outcome of hospital admission or death, with a reduction from 14.1% to 7.3%. In the full data analysis at the end, the relative risk reduction dropped to 30%, first and foremost because the event rate in the placebo group suddenly went down to 9.7%. So not exactly sure what happened in the control group there, but overall, again, 30% relative risk reduction, same ballpark as what I've shown you with Fluvoxamine on the previous slide. I don't know by when this drug may be approved in Canada. I haven't heard any timelines. Next slide. In contrast, here, Niamat, Trelvir, Ritonavir, or Paxlovid, and we finally have a peer-reviewed publication, came out roughly a month ago in the New England Journal of Medicine, before we had to trust the Pfizer to present the right data to us without having had the actual journal article. But now it's out there. This is the EPIC-HR, so EPIC high-risk RCT. And in those patients with high risk for progression, the study showed a relative risk reduction of 89% for hospital admission or death. So again, similar ballpark as what I've shown you for Sotrovimab and Remdesivir previously. And it also resulted in a 10-fold decrease in viral load, which may have a positive impact in reducing further transmissions. I showed you here the table with the figure with the subgroup analysis as well. And as you can see, the effect is quite similar across all the subgroups. It looks like in the older population, it's even more effective than in the younger population. The exception to this rule is if your baseline SARS-CoV serology status is positive, there's still a statistically significant effect, but it's just borderline, as you can see there. And at the very bottom, you see patients that have received monoclonal antibody treatment at the same time. And there, it seems like there might not be a significant effect anymore. So immunity certainly plays into the benefit of Paxlovid, and we are very curious to see how Paxlovid actually works in the vaccinated or otherwise immune population. Next slide. And the answer, okay, if we first talk about the drug-drug interactions here, already mentioned by Alan, this is just from the Sanford Guide screenshots. So there's a long list of drugs that you need to consider and make sure, if you are able to use Paxlovid in your practice, to make sure that you don't have any drug-drug interactions, or you need to manage them accordingly. Next slide. Going back to the question, what to do with those immune patients where we would be using Paxlovid at this point of time if their estimated risk is more than 5% for hospital admissions. The EPIC-SR, so EPIC standard risk RCT, will probably give us that answer. This is the summary here on what's known about EPIC-SR provided by the Ontario Science Table. And the bottom line is that the primary outcome, which was alleviation of symptoms, was not met in the interim analysis that had been shared. But it looks like there's a borderline significant effect on hospitalization, reducing the risk from 2.3% in that population, so much lower than what you would have seen in the control group in those higher risk patients, obviously, down to 0.7%, so a relative risk of 0.3, which will translate into a number needed to treat of 61 patients. But again, not statistically significant, may just be a power issue. We are all looking forward to see the final results of this trial, which may change again how we are using this drug at this point of time. Next slide. So in summary, the new antivirals, nirmatrelvir, ritonavir, so Paxlovid, approved for use in Canada for 2 months now. Canada has ordered 1 million courses, originally also ordered 500,000 courses of molnupiravir, as I mentioned, not approved yet. Time window for these two options is up to 5 days from onset of symptoms, which can be very tight when you consider that patients typically wait a day or two until they feel like, yeah, I really feel under the weather, I might need to get tested, then they need to get tested, you need to get the results. So 5 days can be tight. The regimen, as Alan previously mentioned, is BID, a 5-day course for either of those two drugs. Next slide. I think Alan already covered this. So there's unproven or harmful treatments out there in the outpatient setting with mild disease. Currently not recommended are colchicine, interferon, dexamethasone, and tocilizumab. The last two being indicated for the more severely sick patients, and you will hear about that in the next presentations that you will see. And then we have a number of drugs that have been unproven in any setting. Ivermectin, just another RCT being published, I believe this or last week, again showing no benefit. So probably the last RCT we will see on this drug. Same for hydroxychloroquine, lopinavir, ritonavir, so Kaletra, an HIV regimen hasn't proven to be effective. Azithromycin, no effect. Vitamin C, vitamin D, and zinc, again, by itself, not an effective drug to treat COVID-19. Okay,